Seniors. Which blood pressure number is more dangerous? Systolic versus diastolic. Understanding the critical numbers on your blood pressure readings is paramount for maintaining your health, especially as you age. For decades, we've seen blood pressure presented as two figures, one stacked above the other, a familiar sight on every reading and a frequent topic of discussion with our doctors. However, the profound implication of these numbers, particularly their differential risk as we advance in years, is often not clearly elucidated. It's crucial to grasp that one of these numbers carries significantly more danger than the other, a reality that becomes increasingly pronounced after the age of 60. This specific number, which is contributing to a greater number of serious health events in seniors, might not be the one you're accustomed to focusing on. As a cardiac surgeon with 20 years of experience, I have witnessed firsthand the devastating consequences of high blood pressure. I have operated on thousands of hearts that have been irrevocably damaged by it, held failing organs in my hands, and seen the heartbreaking aftermath of repeated strokes. I have also observed families fractured by the preventable loss of loved ones who, sadly, overlooked the wrong number, pursued the wrong health target, and ultimately paid the highest price. The insights I'm about to share are not based on speculation, but on extensive research that has followed millions of patients over many years. This is not theoretical knowledge. It is life or death information that every individual over 60 years old needs to comprehend. By the end of this discussion, you will be equipped to identify which number poses the greatest threat to your heart, your brain, and your very life. You will understand precisely why this number becomes more perilous with increasing age, and most importantly, you will know what concrete steps you can take, starting today, to mitigate this risk. This could very well be the most impactful 15 minutes you dedicate to your well-being this year, so I urge you to stay engaged, as the revelation may come as a profound surprise. To truly grasp the significance of these numbers, we must first establish a fundamental understanding of what they represent. When a medical professional places a blood pressure cuff around your arm and inflates it, they are measuring the force exerted by your blood against the walls of your arteries. This pressure is not static. It fluctuates dynamically with each heartbeat. This pulsatile nature is why we receive two distinct measurements. The upper number, known as the systolic pressure, reflects the maximum force applied when your heart contracts forcefully, propelling blood into your arteries. You can visualize this as the crest of a wave, the peak of exertion. Conversely, the lower number, the diastolic pressure, indicates the minimum pressure maintained when your heart relaxes between beats, a period of relative calm. For instance, a reading of 150/90 signifies that the peak pressure reached is 150 millimeters of mercury, while the pressure during the heart's resting phase is 90 millimeters of mercury. For many years, medical practice placed considerable emphasis on both figures. An elevated reading in either number constituted hypertension, necessitating treatment. However, over the past 3 decades, extensive research involving longitudinal studies of millions of individuals has unveiled a compelling pattern. This pattern, tracking heart attacks, strokes, and cardiovascular disease, mortality, becomes increasingly evident and significant as people age. Consider the contrasting experiences of 2 patients, Margaret and Robert, whose stories powerfully illustrate the central point I aim to convey. Margaret, a vibrant 73-year-old, presented for a routine cardiology evaluation. Her blood pressure that day was recorded as 165/70. Margaret was remarkably pleased, proclaiming, "Dr. Whitmore, my bottom number is perfect. I've been diligently working to keep it below 80, and look, it's only 70. My top number is a little high, but my doctor assured me that as long as my diastolic pressure is good, I shouldn't be overly concerned." I regret to say that Margaret's physician's advice proved tragically misguided. Just 6 months later, Margaret suffered a massive stroke, leaving her paralyzed on the left side of her body and with severely impaired speech. The independent, spirited woman who had entered my office was now entirely dependent on her daughter for even the most basic daily necessities. The root cause? Years of unchecked elevated systolic pressure had been silently inflicting damage upon the arteries in her brain, a silent catastrophe while the medical community celebrated her seemingly excellent diastolic reading. In stark contrast, Robert, a 68-year-old gentleman, presented with a reading of 128/95. Robert was deeply anxious, expressing, "Doctor, my bottom number has been gradually increasing for years. I've read online that diastolic pressure is the true killer, indicating that my heart is constantly overexerting itself. I live in terror of having a heart attack." Following his concerns, I initiated a comprehensive cardiac assessment for Robert, including a stress test, an echocardiogram, and a coronary calcium score. Fortunately, his heart was in excellent condition, and his arteries showed minimal plaque buildup. While it was indeed necessary to address his elevated diastolic pressure, his actual risk was nowhere near the catastrophic level he feared. These two individuals, with their distinct blood pressure profiles and vastly different outcomes, underscore the critical question you are here to have answered. Which number, systolic or diastolic, poses the greater danger? Before I provide a definitive answer, it is imperative to understand a crucial nuance. The answer to this question is not uniform for everyone. The risk associated with each number shifts considerably with age. If you are 30 years old, the implications are different than if you are 70. Your age fundamentally alters which number represents the more significant threat. Given that my primary audience comprises individuals over 60, I will focus on the research findings that are most relevant to your age group, as this is where the evidence becomes exceptionally clear and where this understanding can literally be the difference between life and death. The body of research that has profoundly reshaped our understanding of blood pressure risk in older adults stems from multiple large-scale studies. The Framingham Heart Study, a landmark endeavor, meticulously followed over 5,000 participants for decades. Similarly, the MR-FIT study meticulously tracked more than 300,000 men. Study after study, encompassing millions of participants, has converged on a singular, unequivocal conclusion. After the age of 60, systolic blood pressure emerges as a far more potent predictor of cardiovascular events than diastolic pressure. In fact, some research indicates that systolic pressure is 2 to 3 times more predictive of heart attack and stroke risk in older adults compared to diastolic pressure. The findings become even more compelling when researchers observed a peculiar phenomenon in many older individuals: a rise in systolic pressure while diastolic pressure either remains stable or even declines. This clinical presentation is termed isolated systolic hypertension, and it precisely describes Margaret's situation. For a considerable period, medical professionals grappled with how to manage this condition. Some posited that if the diastolic pressure was within the normal range, perhaps this was not truly hypertension, but a natural consequence of aging. We now possess irrefutable evidence that this perspective was dangerously flawed. Isolated systolic hypertension is not a benign condition, nor is it simply an inevitable part of aging. It is a perilous state that significantly escalates the risk of heart attack, stroke, heart failure, and kidney disease. Scientific studies have demonstrated that effectively treating isolated systolic hypertension can reduce stroke risk by an astonishing 30 to 40%, and heart attack risk by 15 to 25%. These are not marginal improvements. They represent monumental gains that translate into the prevention of thousands of deaths and debilitating disabilities annually. Therefore, let me state this unequivocally. If you are over 60 years of age, your systolic blood pressure, that top number, is the most dangerous figure on your blood pressure reading. This is the number that most reliably indicates your future risk of experiencing a heart attack or stroke. This is the number that demands your vigilant attention and requires rigorous control. Now, does this imply that diastolic pressure is inconsequential? Absolutely not. Diastolic pressure remains vital, but its significance and the way it influences overall risk are different, and understanding this distinction is crucial for effective treatment strategies. To fully comprehend why systolic pressure becomes more dangerous with age, we must delve into the underlying physiology. Our arteries are not rigid, inflexible conduits. Rather, they are elastic, flexible tubes that expand slightly with each surge of blood from the heart and then recoil. This elasticity plays a crucial role in absorbing some of the peak pressure generated by each heartbeat, thereby smoothing out the force and shielding our vital organs from the constant pounding impact of blood flow. In youth, arteries are supple and readily accommodate the blood volume, contributing to relatively lower systolic pressures and higher diastolic pressures due to the inherent elasticity of the vessels. However, as we age, a natural process of arterial stiffening occurs. The elastic fibers within the arterial walls degrade and are progressively replaced by less pliable collagen. Calcium deposits can accumulate within the arterial walls, and atherosclerotic plaques, a buildup of fatty deposits, can form. These changes transform our arteries from resilient rubber bands into more rigid pipes. Consequently, when the heart contracts to eject blood, these stiffened arteries are unable to expand effectively to absorb the surge of pressure. This forces the systolic pressure to rise dramatically. Conversely, during the resting phase between heartbeats, these stiff arteries lose their ability to recoil with the same vigor, often resulting in a stable or even decreased diastolic pressure. This physiological transformation is the primary reason why isolated systolic peak hypertension is so prevalent in individuals over 60. It is a direct manifestation of arterial stiffening. Crucially, elevated systolic pressure is not merely an innocuous marker of arterial stiffness. It is an actively damaging force. Each surge in systolic pressure delivers a relentless pounding to your organs, your brain, your kidneys, your heart, and your eyes. The delicate network of blood vessels supplying these vital organs sustains injury with every single heartbeat. Imagine the impact of constant waves crashing against a seawall. While occasional large waves may cause minor damage, thousands upon thousands of waves, day after day, year after year, will inevitably lead to cracks and eventual structural failure. This is precisely the damage that elevated systolic pressure inflicts upon your blood vessels, initiating a cascade of micro-injuries. The body attempts to repair these injuries, but this repair process itself can trigger further stiffness, inflammation, and the progression of atherosclerosis, creating a detrimental cycle. The brain is particularly vulnerable to this sustained onslaught. The minuscule blood vessels that nourish brain tissue are ill-equipped to withstand chronic high pressure. They can develop microaneurysms, fragile outputchings that are prone to rupture, leading to hemorrhagic strokes. Alternatively, these vessels can become narrowed and obstructed, resulting in ischemic strokes. Even in the absence of overt major strokes, chronic high systolic pressure contributes to countless microscopic silent strokes, areas of brain tissue that die off due to insufficient blood supply. Over time, this cumulative damage can manifest as vascular dementia, characterized by memory loss, confusion, and profound personality changes. Many cases diagnosed as Alzheimer's disease are, in reality, a form of vascular dementia stemming from years of uncontrolled systolic hypertension. The heart itself bears a significant burden. This vital muscle is forced to generate immense force to pump blood into arteries that are both stiff and under high pressure. Over time, the heart muscle thickens in an attempt to meet this increased demand, a condition known as left ventricular hypertrophy. This thickening is profoundly dangerous, as a thickened heart becomes a stiffer heart. It loses its ability to fill adequately with blood, and its pumping efficiency diminishes, ultimately leading to the development of heart failure. This is not a consequence of a single heart attack, but rather the result of years of the heart laboring against the relentless resistance of elevated systolic pressure. The kidneys, with their millions of tiny filtering units, each supplied by delicate blood vessels, are also profoundly affected. Elevated systolic pressure damages these vessels, leading to kidney disease. As kidney function declines, their ability to regulate blood pressure diminishes, exacerbating the hypertension, which in turn further damages the kidneys, creating another vicious cycle that can ultimately necessitate dialysis. Now, let me address a point of frequent confusion, and one that requires direct clarification. Does a low diastolic pressure guarantee safety? Unequivocally, no. In fact, a concerning phenomenon known as a wide pulse pressure can occur in some older adults with severely stiff arteries. In these individuals, systolic pressure may be exceptionally high, while diastolic pressure is remarkably low, sometimes falling below 60 or even 50 millimeters of mercury. This significant gap between systolic and diastolic pressure, known as a wide pulse pressure, is itself an independent risk factor, signifying profound arterial stiffness. The insidious danger here lies in the fact that during the resting phase of the heartbeat, the pressure within the arteries drops precipitously. The coronary arteries, responsible for supplying blood to the heart muscle itself, receive the majority of their blood flow during this diastolic period. If diastolic pressure is excessively low, the heart muscle may not receive an adequate supply of oxygenated blood, potentially leading to angina, chest pain, and even heart attacks, even if the coronary arteries themselves are not significantly blocked. This condition is termed demand ischemia. Therefore, the ideal scenario for an older adult is not a sky-high systolic pressure accompanied by a low diastolic pressure. The optimal state involves the well-controlled status of both numbers. However, if forced to prioritize and identify the single most critical number to bring under control, the scientific evidence is overwhelmingly clear. It is the systolic pressure. This is the number that surges with each heartbeat, relentlessly impacting your organs. Let us now turn to the prevailing clinical guidelines, as this information is directly relevant to your discussions with your physician. In 2017, the American College of Cardiology and the American Heart Association jointly revised their hypertension guidelines, lowering the threshold for defining hypertension to a systolic pressure of 130 mmHg or higher, or a diastolic pressure of 80 mmHg or higher. However, these updated guidelines also strongly emphasize that for older adults, controlling systolic blood pressure should be the primary therapeutic objective. For the majority of individuals over 65, the target is to achieve a systolic pressure below 130 mmHg. Some research, such as the SPRINT trial, suggests that for very healthy older adults, even lower systolic targets, such as below 120 mmHg, may confer significant benefits, demonstrating substantial reductions in heart attack, stroke, and mortality with intensive systolic blood pressure control. Nevertheless, for frail elderly individuals, particularly those exceeding 80 years of age and managing multiple complex medical conditions, slightly more lenient targets may be deemed more appropriate to avert potential complications associated with overly aggressive treatment. The overarching message is undeniable. If your systolic pressure consistently registers above 130 mmHg, prompt action is imperative. You must collaborate with your physician to implement strategies to lower this number. And if your doctor dismisses an elevated systolic pressure solely because your diastolic reading is within the normal range, it is incumbent upon you to initiate a serious dialogue. Present the scientific evidence. Specifically, inquire about the management of your isolated systolic hypertension. Your well-being and indeed your life may depend on it. Regarding therapeutic interventions, the question arises, how does one effectively lower that elevated systolic number? The answer invariably involves a dual approach: comprehensive lifestyle modifications, coupled with, in most cases, pharmacological intervention. Let us explore both facets, as a holistic strategy is essential for optimal outcomes. Lifestyle changes form the bedrock of blood pressure management. Foremost among these is sodium restriction. This is of paramount importance for blood pressure control, particularly for systolic pressure. The average American consumes well over 3,400 milligrams of sodium daily, far exceeding the recommended maximum of 1,500 to 2,000 milligrams for individuals with hypertension. A significant reduction in sodium intake can lead to a reduction in systolic pressure by 5 to 10 points, a clinically meaningful improvement. This entails diligently cutting out processed foods, abstaining from adding salt at the table, and meticulously reading food labels. Implementing these changes alone can enhance the efficacy of medications or, in some instances, diminish the need for them altogether. Secondly, weight management is critical for those who are overweight. For every kilogram of weight lost, approximately 2.2 pounds, one can anticipate a reduction in systolic blood pressure of about 1 point. Therefore, losing 10 pounds could translate to a 10-point decrease in systolic pressure. When combined with sodium restriction, lifestyle modifications alone could potentially yield a 15 to 20-point reduction in systolic pressure. Thirdly, regular aerobic exercise is indispensable. Activities such as brisk walking, swimming, or cycling, which elevate your heart rate to a moderate intensity for at least 30 minutes on most days of the week, offer multifaceted benefits for blood pressure regulation, including, over time, an improvement in arterial elasticity. The benefits extend beyond mere weight loss. The exercise itself acts as a potent therapeutic agent. Fourthly, moderating alcohol consumption is advised. If you choose to drink, limit your intake to moderation. Consuming more than 2 standard drinks per day for men or 1 for women can significantly elevate blood pressure, especially systolic pressure. Fifthly, stress management is crucial. Chronic stress triggers the release of cortisol and adrenaline, both of which are potent blood pressure elevators. Engaging in practices such as meditation, yoga, or deep breathing exercises, whatever your preferred method for calming your nervous system, and doing so daily, can be highly beneficial. However, it is imperative to acknowledge the reality. For the vast majority of individuals over 60 with systolic pressures exceeding 140 or 150 millimeter Hg, lifestyle modifications alone will likely prove insufficient. Pharmacological intervention is almost invariably necessary. Let me be absolutely clear on this point. Commencing blood pressure medication is not a sign of failure, nor does it indicate a lack of personal effort. For older adults experiencing arterial stiffness and elevated systolic pressure, medication is frequently a life-saving intervention. A diverse array of blood pressure medications exists, including diuretics, ACE inhibitors, angiotensin II receptor blockers, ARBs, calcium channel blockers, and beta blockers. Each class functions through distinct mechanisms. Many individuals require a combination of 2 or even 3 medications to achieve adequate systolic pressure control. This is a common and entirely acceptable therapeutic approach. Your physician will judiciously select medications based on your other existing medical conditions. For instance, if you have diabetes, certain medications offer kidney protection. If you have heart failure, other agents can enhance cardiac function. The paramount objective is to identify a therapeutic regimen that effectively controls your systolic pressure without imposing intolerable side effects. If a particular medication causes dizziness, a persistent cough, or any other adverse reaction, it is vital to communicate this to your doctor. Do not simply discontinue the medication on your own. Request an exploration of alternative options. The breadth of available medications is so extensive that virtually everyone can find a regimen that is both effective and well tolerated. Furthermore, it is absolutely critical to understand that once you initiate blood pressure medication, relying solely on infrequent readings at your doctor's office every 6 months is insufficient. Regular at-home monitoring is essential. Invest in a reliable, high-quality home blood pressure monitor. For the initial week of any new medication or dosage adjustment, check your blood pressure both in the morning and the evening. Once your pressure stabilizes, continue monitoring at least weekly. Keep a detailed log of your readings and bring it to all your appointments. This data is invaluable for your physician in optimizing your treatment plan. Some individuals experience what is termed white coat hypertension, where their blood pressure is normal at home, but elevates significantly in the clinical setting due to anxiety. Conversely, others may have masked hypertension, where their readings appear normal in the doctor's office, but are elevated at home, a situation that often carries a greater risk. Consistent at-home monitoring effectively identifies both of these patterns, providing you and your doctor with an accurate, real-time picture of your blood pressure fluctuations. Now, let me address a pervasive misconception that I encounter frequently. But, Dr. Whitmore, people will say, my father lived to be 90 with high blood pressure and never took medication. Why should I? This is a classic example of survivorship bias. For every individual who enjoys a long life despite untreated hypertension, there are undoubtedly many more who succumb to stroke or heart attack in their 60s or 70s. Their stories are sadly not told because they are no longer with us. The overwhelming body of evidence unequivocally demonstrates that treating elevated systolic pressure saves lives. It prevents strokes. It averts heart attacks. It safeguards against heart failure and kidney failure. the number of individuals requiring treatment to prevent a single cardiovascular event is remarkably small. We are discussing a scenario where treating approximately 15 to 20 individuals over a 5-year period can prevent one stroke or heart attack. These are exceptionally favorable odds for a treatment that is generally well tolerated. Another common refrain I hear is, "I feel perfectly fine. My blood pressure is high, but I have no symptoms. Why should I treat something that isn't bothering me?" The critical truth here is that by the time high blood pressure manifests with noticeable symptoms, significant and often irreversible damage has already occurred. Strokes happen suddenly, and heart attacks strike without warning. Your body does not offer subtle indications that your systolic pressure has been excessively elevated for an extended period. Often, the very first symptom is the catastrophic event itself. This is precisely why hypertension is tragically known as the silent killer. It does not announce its presence. It operates insidiously, year after year, silently damaging your arteries, weakening your heart, and meticulously laying the groundwork for future disaster. To await symptoms is to wait far too long. Allow me to also dispel a particularly dangerous myth: the notion that blood pressure naturally rises with age and that any attempt to intervene is futile or even harmful. Some believe that lowering blood pressure too aggressively in older adults can lead to reduced blood flow to the brain, contributing to confusion and an increased risk of falls. This perspective is largely unfounded. While it is true that we must exercise caution to avoid overly rapid or excessively low blood pressure reductions in very frail elderly individuals, the overwhelming majority of people over 60 derive profound benefits from effective blood pressure management. The HIVET trial, specifically investigating individuals over 80 with hypertension, provided compelling evidence. It demonstrated that treatment reduced the incidence of stroke by 30% and mortality from all causes by 21%. Treating blood pressure in older adults does not harm them. Rather, it provides essential protection. The key lies in implementing treatment appropriately, with meticulous monitoring and judicious adjustments. In conclusion, let me synthesize this information into clear, actionable steps. If you are over 60 years of age, here is precisely what you need to do. Firstly, know your numbers. When was the last time you actually checked your blood pressure? If it has been longer than a month, make it a priority to have it checked this week. If you do not currently own a home blood pressure monitor, I strongly urge you to purchase one. They are relatively inexpensive and widely available. Ensure you acquire a model that has been validated for accuracy. Secondly, focus specifically on your systolic number. If it consistently registers above 130 mm Hg, and particularly if it is above 140 mm Hg, you must engage in a comprehensive discussion with your physician about initiating treatment. Do not allow anyone to dismiss the significance of an elevated systolic pressure simply because your diastolic reading appears normal. Isolated systolic hypertension in individuals over 60 is a serious condition that demands effective management. Thirdly, implement lifestyle modifications regardless of your current blood pressure readings. Even if your blood pressure is currently within the normal range, adopting these healthy habits will significantly contribute to maintaining it that way in the future. Diligently reduce your sodium intake. Strive to maintain a healthy body weight, engage in regular physical activity, moderate your alcohol consumption, and proactively manage your stress levels. These are not optional additions to your health regimen. They are fundamental pillars of well-being. Fourthly, if your doctor prescribes blood pressure medication, adhere to the regimen consistently. Utilize reminders, pill organizers, or any method that helps integrate medication taking seamlessly into your daily routine. Irregular medication intake can lead to fluctuations in blood pressure, which is often more detrimental than a consistent mild elevation. Consistency is paramount. Fifthly, monitor your blood pressure at home and meticulously keep records. This practice empowers you with vital information and provides your physician with essential data to guide treatment decisions. It transforms you from a passive recipient of care into an active, informed partner in your own health journey. Sixthly, never discontinue or alter your prescribed medication without first consulting your physician. This cannot be stressed enough. Abruptly stopping blood pressure medication can precipitate a dangerous rebound spike in pressure. If you are experiencing any side effects or have concerns, contact your doctor. Work collaboratively to adjust the treatment plan. Avoid making unilateral decisions. And seventhly, attend regular medical checkups. Blood pressure control is not a static, set-it-and-forget-it endeavor. Your physiological needs can evolve over time. Your kidney function may change. You may be prescribed other medications, and your blood pressure regimen may require adjustments. Remain actively engaged with your healthcare team. I would like to conclude by revisiting Margaret, the patient whose life was irrevocably altered by a devastating stroke, a consequence of her untreated elevated systolic pressure. I often reflect on her story, not because she was an anomaly, but because she represents countless individuals who are currently living with the same perilous pattern: elevated systolic pressure with a normal or low diastolic reading, falsely reassured by the seemingly acceptable lower number. If Margaret had possessed the knowledge I have shared with you today, if she had understood that her systolic pressure of 165 was the true source of danger, and if she had insisted on appropriate treatment, I genuinely believe she would still be living an independent life, pursuing her passions and enjoying her days on her own terms. Tragically, that vital knowledge never reached her. She relied on a healthcare system that failed to clearly communicate the differential importance of the numbers. You, however, now possess that crucial knowledge. You understand that after the age of 60, your systolic blood pressure is the critical determinant, the dangerous number, the one that most accurately predicts your future cardiovascular health. You comprehend the physiological reasons for its rise with age, linked to arterial stiffening. You recognize that effectively managing elevated systolic pressure can prevent strokes, heart attacks, heart failure, kidney disease, and even cognitive decline. And you understand that treatment is effective and generally safe when administered appropriately. This information represents power, but its true value is realized only when acted upon. Check your blood pressure regularly. Have an open and informed conversation with your doctor. Embrace the necessary lifestyle changes. Take your prescribed medications consistently. Monitor your progress diligently. Remain actively engaged in your healthcare. Your heart, your brain, your kidneys, and ultimately your life itself depend on maintaining control of that systolic number. Before I conclude, I wish to implore you to undertake two important actions. Firstly, please subscribe to this channel. My commitment is to deliver clear, evidence-based health information that cuts through confusion and provides you with the essential knowledge you need to make informed decisions about your well-being. Secondly, I urge you to share this video. Consider your friends, your spouse, your siblings, and your wider circle of acquaintances. How many individuals over 60 do you know who check their blood pressure, but focus solely on the lower number? How many may have elevated systolic pressure without fully grasping the inherent danger? Sharing this video could quite literally save someone's life. And finally, please leave a comment below. Share your own blood pressure story. Were you surprised to learn that systolic pressure is more dangerous after age 60? Have you encountered challenges in managing your blood pressure readings? What questions do you still have? I personally read every comment, and your feedback is invaluable in shaping content that truly serves your needs. Your heart has been beating faithfully for over 60 years, performing billions of contractions without fail. It deserves your utmost attention and dedicated care. Effectively controlling your systolic blood pressure is one of the most significant steps you can take to protect this vital organ. Do not allow that top number to deceive you into believing all is well when it is elevated. It is the number that demands your vigilance. It is the dangerous number. And now, you know.